Hello, my name is Raisha Noorani. I am a GP in London, and I'm now saying GP. I used to say GPST3. So I finished my training, officially a GP now, yay! And I'm here to talk to you about the CSA. Now I want to apologise first because it's taken me a really long time to get this video out, and I think part of that has been because, you know, as you will notice on the background, I'm in a new place and there's been a lot of changes, and actually I think the last few months and changing from being a very, you know, nurtured trainee into being thrown into the wide world of general practice has been a bit of a baptism of fire. Lots of trying to picking up new knowledge and seeing how things work. In fact, part of me feels like I should do a video on it because I wish I knew all the stuff that I've suddenly started to learn about, and maybe if there's enough interest, I'm happy to do a video on what happens after VTS, life after VTS. Now, in terms of what I want to talk to you about today, we're going to discuss negotiation in the CSA, and I think when I look back, I think negotiation is one of the harder things when it comes to the CSA. I feel like negotiation is one of those where the more experience you have, the better you seem to do with negotiation. So the more you interact with patients, the more comfortable negotiation becomes. So it's probably an indicator of your experience, and at ST3 that experience is very limited. And I also think as trainees, we're not happy to deal with confrontation in the same way, and we are perhaps a bit more patient-led, which is, you know, which has some benefits, but I think when it comes to negotiation it can make it a bit more difficult for us to do. So my negotiation way of doing things was very much learning the key things that people have to negotiate, GPs have to negotiate about, and focusing on how I would deal with those. And I think that's not a bad way to approach a CSA context, and I'll talk you through my revision for how to approach that negotiation. So negotiation, what is it? Essentially, it is a difference in the agenda, or there's a dichotomy of interest between what the patient wants and what you want. And negotiation is coming to that zone of or that area where both of you can agree on what to do next and what the course of management should be. So how do you know this is going to be a negotiation station? So essentially there are so many clues early on in that consultation to tell you that this is going to be your negotiation station. So negotiation doesn't happen, you know, at that last 10 minutes. If you go right back to the beginning, when you're asking your ideas, your concerns, your expectations, yes, the dreaded ICE, there is a reason for this, and that is actually within those 3, you know, statements, you will have worked out that actually, oh, this might turn into a bit of a difficult one when it comes to management plan, because this patient is set on the idea of X, Y, and Z, and I think that might not be appropriate. So essentially, from the moment you ask about ICE, you've got your, you know, the light bulb going on in your head going, actually this might end up as being a negotiation station. So really that kind of makes you think that or makes you realise how important that ideas and concerns and expectations are. And in real life, you know, there are patients who you keep doing something for them and you can't work it out. They just don't seem to be happy with whatever you seem to be doing, and that's because you kind of haven't addressed that underlying expectation or concern or idea that they have. Okay, so then you know, within the first 10 minutes you will know that this might end up being a negotiation station. So then you kind of have the ability to plan for that, and start thinking about how you're going to give context to your management to get the patient onto your side, and for them to understand why you're doing something. Now, with me, like I said, with negotiation stations, I very much had, you know, key things that I knew that people might negotiate about and have a way of managing those, and that helped with me with my anxiety. And also, I mean, negotiation means you're going to have to think creatively, because the patient's not going to just take your management plan unless you can persuade them or find something that's more feasible for them to do. And so to be able to think of those ideas, you need to think, you know, outside the box. You have to think more creatively, and I think that's very hard in, you know, 5-minute management plan. So I think having a few ideas already there, and then you can just take them and see if that will work with that patient. Is not a bad way of doing it. So the way you approach the management of negotiation is, I think we should do this because, so you're giving context and an explanation behind, beyond it, and then suggest an alternative if they don't seem to come round to your initial idea. And I think if you have those two major principles, so explanation and alternative, then actually you can manage a lot of the negotiation stations. So let's go through common things. The first one is patients want to be referred to, a specialist, XYZ department. So how are you going to manage that situation? And the things that I would often say is, actually, I completely agree with you. You want to be seen by this ophthalmologist or this dermatologist, but actually, if this is something we see commonly in general practice, and being able to say that allays their concerns that you have no clue about this and they must see a specialist, so you're kind of telling them that you have experience, and then saying things like, okay, well, I would suggest we do this. Even if I was to refer you today, it's very likely that the specialist will say exactly the same. So how about we try it first and then see where we go? And I think that for referrals certainly does help, because the patient can sense that there's no point in, being referred and being told exactly the same thing. I think always keeping the option of a referral open is not a bad suggestion. If this doesn't work, why don't we relook at this? Or let's give this a trial for the next couple of months, and if it's not settling, then perhaps we can look at this referral. If something is completely not appropriate and it's not, it's not something that you would do, then I sometimes think a good way of managing a referral one is actually just distancing yourself and saying something like, even if I was to refer you, because it doesn't meet our CCG guidelines or our local guidelines on referrals, it's very likely that my referral would be rejected. So this isn't because this is not an appropriate referral. And actually, the patient might be angry and they might be annoyed, but it doesn't give them as much to be able to argue with when it comes to discussing it with you, and it's not a personal thing, it's just you explaining a very clear statement of fact. So that's referrals. The second thing that people often find that they're negotiating about is there's some sort of medication. It may be antibiotics, which are all very much commonplace and we see all the time, whether they need antibiotics, but it may be any medication, diazepam, they want more steroids for, a skin condition, all of those things. And once again, you're doing exactly the same thing, so you're giving context. I don't think you need antibiotics because when I listen to your chest, it's clear. When I do this, it's fine. I think you don't need any more steroids because actually we can already see that this is not improving the situation. I don't think that you should have this because... So one of the reasons is because it's not indicated. The second reason might be because of the side effects. I don't think you need this because actually when you look at the side effects, you could get this, this and this, and I'm not sure it will benefit you enough to explain or to justify these side effects. Or as we use in antibiotics, I don't think you need this because actually if we were to treat you for this, the chances of improvement are no better, so the numbers needed to treat, a statin is probably a better example, these are the numbers needed to treat, and actually it only benefits a very small amount of people. I'm not sure that this is the most, not sure it's worth it if you think about the side effects that you're definitely going to get with this medication. So talking about why you're not going to give it, and then offering alternatives, Actually, there are other things that might make you feel better. You can get some spray for the back of the throat. I can write down the name for you. You can pick that up from the pharmacist. Or actually, how about we look at how much emollient you're using so you don't need to use as much steroid. These things are better for you. Maybe perhaps we should try this. So you explained why and you're offering an alternative. What about things that are not covered on the NHS is another one where you might find that you need to negotiate with the patient with. So a cosmetic surgery, for example. And this is once again having a statement in your head, knowing what you're going to say. Unfortunately, this is not covered by the NHS. Even if I was to refer you, it would be rejected. This is a private or a cosmetic surgery. It's not covered by the NHS. You would have to do this privately. And give an alternative. I'm happy to write you a letter for a private referral if this is what you would like, and something like that. So that covers your cosmetic and private sort of things. And then there's the unusual ones, so things like what if you need to negotiate someone who comes in with multiple problems? So then exactly having a few statements, and my statements in my head would be for multiple problems, that this is, I know that you have a lot of things that you want to discuss today. The problem is that I don't want to discuss things half-heartedly. I feel like within 10 minutes we should probably consider one or two of these problems and do them properly. Otherwise I feel that in the rush we may miss something that's important. Or things like, so how about you go through and tell me what you think is the most important to you, or I go through this list and I'll see which one of these makes me most concerned. Or next time when you come and see us, why don't you book in for a double appointment, and we'll see if we can cover a bit more of this in the following appointment. So just thinking, those things of booking a double appointment, my referral might be rejected, those things you might not think on the spot, but if you have them and you practice them, then they come a bit more naturally on the day. What about something completely different, in the sense that you are suggesting a course of treatment and the patient doesn't want it? That's also a negotiation, because there's still a dichotomy of interest there. So a common one might be blood pressure medication or statin medication, where often you might suggest it and the patient's not keen to start those things. And I think you're doing exactly the same thing, so explaining why. I think this is important because we know that when you get to a certain risk, or your Q risk is 25%, that means that you have a 1 in 4 chance of having a heart attack or stroke in the next 10 years. This is quite high. This is why I would suggest taking it. Or, this will benefit you because of whatever reason. So you've explained it, and you then have to find an alternative way of managing this. So the patient goes, well, I don't want 80 milligrams, I'm getting pain, or whatever it is. Then you might say, well, okay, it's not the guidelines, but how about we start at half of that dose and work you up to 80? How about we review this in a few months? Just so you're doing exactly the same thing. You're offering an alternative that may not be exactly what you planned and won't be exactly what the patient planned, but it's a journey and a starting point to finding a solution. Let's review this again in 6 months. So to summarize, what we've done is we've talked about negotiation, what it is, and how to be aware that this will be a negotiation station. And then we've talked about common negotiation situations: referrals, medications, cosmetic surgeries, multiple problems, and then when the patient doesn't really want what you're offering at that point. I hope that's useful. Let me know if you want a post VTS video. Please write your comments below if there's anything else you want me to cover. I have been speaking to a few people, and I'm really pleased to hear that so many of you, particularly the ones who are retaking, because I know that can be a bit more difficult, actually have passed in the last CSA, so I'm really pleased to hear that, and I hope that this continues to benefit people. Please subscribe and please share this amongst people, other trainees, so it feels that what I'm doing is actually being useful to you and to other people. Alright, thank you very much. Bye.